Today, we're going to explore how EMS professionals recognize, assess, and appropriately intervene when caring for at-risk populations. This includes pediatric, geriatric, abused, and trafficked individuals. These patients often cannot advocate for themselves, so our role in early recognition and action is critical. This material is based on national EMS education standards. By the end of this lesson, you will be able to locate high-quality national training resources, understand what makes certain patients vulnerable, identify warning signs of abuse or trafficking, and apply correct EMS actions, including documentation, reporting, and patient advocacy. The DHS Blue Campaign provides national-level education on recognizing human trafficking. It includes videos, symptom lists, safety tips, and reporting channels. These materials help EMS personnel understand victim behavior, physical indicators, and how to safely respond without escalating risk to the patient. These resources also help us understand the trauma-bonded psychology many victims display. Domestic violence is a major contributor to EMS 911 call volume. The National Prevention Toolkit teaches screening techniques and trauma-informed approaches. In our EMT lesson plans on this subject reference the anatomical sites most frequently injured and emphasize the need for careful scene awareness and documentation. We'll get into some of this in a little bit, but if you want to dive deeper into the reference material, I encourage you to pull up the lesson plans and take a look. At-risk populations vary widely, but they share a common characteristic: increased vulnerability due to dependence on others for care, protection, or support. This reliance can place individuals at greater risk for neglect, abuse, exploitation, or unmet medical needs. We will examine two populations frequently encountered by EMS personnel, children and older adults, and discuss the unique challenges they face. We will start with the pediatric population first. Developmental stages dramatically change how a child presents, responds to stress, and communicates. A toddler may respond to fear by becoming silent and withdrawn, while a school-age child might become clingy or panicked. A teenager might underestimate the severity of their symptoms because they're trying to appear tough. Importantly, signs of trauma or illness can look very different depending on age. Infants may only show irritability, poor feeding, or be lethargic, while toddlers may not have the vocabulary to describe pain. Older children might minimize or hide symptoms, especially in cases of abuse. Understanding where the child is developmentally helps you interpret behavior, crying, silence, and physical cues. Unlike adults, pediatric patients often cannot tell you what happened. Very young children may not have the language skills to express what hurts, when it started, or how severe it is. Even older verbal children may be influenced by whoever is in the room with them. This is especially important when abuse or neglect is a concern. Children may be coached on what to say. They may fear punishment if they reveal the truth. They may simply lack the words to explain symptoms like abdominal pain, dizziness, or emotional trauma. A key EMS skill is reading non-verbal clues such as posture, eye contact, reactions to caregivers, and overall demeanor. The child's behavior during your assessment may be your most accurate indicator of underlying danger. Children aren't just small adults. They have unique physiology that makes them more vulnerable to rapid deterioration. Some key differences are higher metabolic rates. They become hypoxic and dehydrated much quicker. Smaller blood volume, which means blood loss that seems minor externally, can represent a large percentage of total volume. Less protective fat and weaker musculature, so they sustain internal injuries from trauma more easily. And flexible bones, which is fewer fractures but more soft tissue and organ damage. Immature immune systems, which cause higher likelihood of infection, sepsis, or rapid decompensation. Because children compensate well until they suddenly don't, EMS providers must recognize subtle signs early. A quiet, listless child is far more concerning than a crying one. Perhaps the biggest risk factor is that children rely entirely on adults for safety, nutrition, hygiene, and emotional support. When caregivers fail, either by inability, neglect, or intentional harm, the child has no ability to escape or protect themselves. This means EMS may be the first healthcare provider the child encounters, the first neutral adult they have contact with, the only person willing to ask the right questions, the only person who sees the living environment. In cases of abuse, neglect, or dangerous home conditions, your observations may be the only chance that child has for intervention. EMS plays a critical role in recognizing suspicious injuries, inconsistent stories, environmental hazards, or concerning caregiver behavior. So when we say pediatrics are high risk, it's not just about medical complexity, it's also about social vulnerability. EMS providers must approach each pediatric call with heightened awareness. Look beyond the immediate chief complaint. Does the child appear afraid of the caregiver? Are injuries or symptoms consistent with the history given? Does the home environment appear safe? Is the child's developmental presentation appropriate for their age? Your assessment must integrate medical, developmental, and social factors to fully understand what's happening. This holistic approach is essential to protecting our most defenseless patients. Geriatric patients make up a large portion of EMS responses nationally, and they represent one of the most vulnerable groups we encounter. What makes them high risk isn't simply their age, it's the complex combination of physiological decline, medical comorbidities, cognitive changes, and social factors that often leave them dependent on others for survival. Let's break down the major areas of vulnerability. First is frailty versus chronological age. When assessing older adults, it's essential to understand that frailty, not the number of birthdays, tells the real story. A frail 68-year-old with poor mobility and muscle wasting may be more vulnerable than an active 85-year-old. Frailty encompasses reduced muscle strength, decreased mobility or balance issues, increased fall risk, poor nutritional status, slower healing, higher risk for rapid decompensation. Frail patients tolerate stressors such as trauma, infection, blood loss poorly. Even minor injuries can result in hospitalization or functional decline. A simple ground level fall can be life-threatening due to frailty, combined with something like anticoagulant use. Next is polypharmacy. One of the biggest clinical challenges is polypharmacy, which is extremely common in seniors these days. Many geriatric patients take 8, 10, or even more medications daily, including blood pressure medications, anticoagulants, diuretics, pain medications, cognitive enhancers, psychiatric medications, herbal or over-the-counter supplements, and this puts them at risk for drug interactions, accidental overdose, medication errors, adverse effects such as dizziness, confusion, or hypotension, and increased susceptibility to bleeding. EMS must always consider whether the current complaint, such as an altered mental status, weakness, or falls, could be the result of medication effects or interactions. Then we have cognitive impairment. Cognition plays a major role in the elderly population. Dementia, Alzheimer's disease, and delirium are common, and each can interfere with communication and history taking. Patients with cognitive impairment may be unreliable historians, not recognize emergencies, forget to take medications or double dose, be easily manipulated by caregivers or abusers, and present with agitation, withdrawal, or confusion rather than clear symptoms. These cognitive deficits also make them particularly vulnerable to abuse and neglect. A patient who cannot remember what happened or who cannot report abuse clearly relies on EMS to recognize subtle environmental and physical clues. Next is loss of independence. As older adults lose functional independence, they become increasingly reliant on others for daily care, such as bathing, eating, medication management, transportation, and finances. This loss of independence increases vulnerability in several ways. Caregivers may become overwhelmed, leading to unintentional neglect. Some caregivers may intentionally withhold food, medications, or mobility aids. Financial exploitation becomes easier. Social isolation reduces the patient's ability to seek help, and nursing home or assisted living transitions may create confusion or depression. When EMS providers enter the home, you may be the only outside professional who sees the patient's living environment. The condition of the home, the cleanliness, access to food and medications, all of these can be indicators of neglect. For EMS, caring for geriatric patients requires a broader lens. You're not just evaluating a chief complaint, you're evaluating the whole person and their support structure. Key considerations include look for signs of malnutrition, dehydration, poor hygiene, assess for unsafe conditions such as clutter, lack of mobility aids, or fall hazards, note contradictory stories between patient and caregiver, identify medication misuse or mismanagement, and consider elder abuse or neglect when injuries are unexplained or inconsistent. Geriatric patients are often hesitant to report mistreatment, either out of fear, shame, or dependency. Your objective documentation and suspicion may be the only voice they have. So when we say geriatric patients are vulnerable, we're recognizing the complex interplay of physical decline, medication burden, cognitive changes, and social dependency. EMS providers must be attentive, patient, and thorough because for many seniors, we are the safety net they have. Moving on to indications of abuse. The face and neck are the most frequently injured areas in domestic violence cases. This is because they are the easiest targets during assault, such as slapping, punching, grabbing, and strangulation. Strangulation is especially concerning. Even if external marks are minimal or absent, strangulation is a high lethality indicator and can cause vascular injuries, airway swelling, neurologic deficits, and delayed respiratory compromise. If a patient reports being choked, this requires immediate attention and documentation regardless of visible injury. The arms are the second most common site because victims instinctively raise their hands and forearms to protect themselves. These are known as defensive wounds. So we want to look for bruises on the outer forearms, contusions or lacerations on the hands, or wrist injuries from grabbing or restraint. When the explanation of the injury doesn't match the pattern, such as a caregiver claiming a child fell, it should raise suspicion. Head injuries, including scalp contusions, facial fractures, black eyes, or oral trauma, may indicate significant blunt force assault. Multiple head injuries at different stages of healing are especially concerning. In pediatrics, head trauma from abuse is the leading cause of fatal outcomes in young children. Back and buttocks are often injured in cases of physical punishment or when the victim is struck while trying to flee. Because these body surfaces are usually covered by clothing, injuries here may not be visible without careful assessment. Bruises on the back or buttocks are highly suspicious in young children, frail elderly patients, or individuals with limited mobility. These locations typically do not align with accidental injury patterns. Injuries to the breasts, such as bruising, tenderness, or bite marks, are rarely caused by accidental trauma. These patients have patterns that strongly suggest interpersonal violence or sexual assault. Because patients may be embarrassed, they might not volunteer this information unless you create a safe environment for assessment. Abdominal trauma is particularly concerning, but even more so in pregnant patients. Assailants often target the abdomen intentionally because it can injure the fetus, it leaves fewer immediately visible marks, and it causes significant internal damage. Complications can include placenta abruption, fetal demise, or internal bleeding. Injuries to the genital area are significant red flags. These injuries may indicate sexual assault, forced intercourse, or physical abuse. Examples include bruising, lacerations, swelling, unexplained pain, or new or recurrent infections. Patients may not immediately disclose sexual assault due to fear, shame, or the presence of the abuser. Approach these findings with sensitivity, confidentiality, and mandatory reporting in mind. One of the strongest indicators of ongoing abuse is the presence of injuries at different stages of healing. This suggests that repeated trauma over time, a pattern of escalating violence, a lack of timely medical care, or control from the abuser preventing access to help. You may see new bruises alongside older yellow-green bruises, or fresh cuts near partially healed scars. When documenting injury patterns, be objective and descriptive. Document size, shape, location, and color of bruises. Avoid labeling injuries as abuse. Just describe what you see, attempt to obtain a private interview with the patient, note behavioral cues and caregiver interactions. Photographing injuries is typically not one of our responsibilities, but with Pulsara, that might be something we do in the future. Your role is not to determine guilt, it is to identify suspicion, care for the patient, document thoroughly, and report as required by law. Recognizing injury patterns can be life-saving. Many victims are unable or unwilling to speak up. Your assessment may be the only chance someone has to escape an abusive environment. Understanding these patterns equips you to intervene effectively and appropriately. Abuse is not always obvious. Behavioral indicators are often the first warning signs. Be alert for controlling or domineering caregivers or partners, explanations that do not match the injury pattern, or unexplained delays in seeking medical care. Victims may minimize, deny, or attempt to explain away injuries due to fear, shame, intimidation, dependence, or coercion. Recognizing these warning signs may be the key to identifying abuse that would otherwise go unnoticed. Early recognition of these indicators can help EMS providers identify patients who may be at risk for ongoing abuse or neglect. Trafficking victims may present with a wide range of unexplained injuries, such as signs of poor living conditions, malnutrition, or untreated infections. Forced labor can produce chronic back injuries, respiratory issues, or hearing loss. Psychological symptoms often include confusion, panic attacks, and fear of authority figures. Cultural and language barriers may further complicate communication. With trafficking, the environment can often tell you more than the patient can. Look for overcrowding, lack of personal possessions, locks on the outside of rooms, or caregivers who interfere excessively with assessment. Document these observations carefully. They may be instrumental in later investigations. Your documentation on these calls should be extremely thorough. At-risk patients often cannot provide clear histories due to age, fear, coercion, or cognitive issues. You may need to rely more heavily on physical exam findings and environmental cues. Separate the patient from others when possible, and remember that caregivers may be the source of the harm. Do not assume they are truthful. Your clinical treatment is typically straightforward. You're going to manage injuries, support the airway, breathing, circulation, and provide appropriate pain management. However, your non-clinical responsibilities such as documentation, reporting, and helping create a safe environment are equally important. Our protocols identify EMS providers as mandatory reporters. So failure to report suspected abuse or neglect can result in a Class 3 misdemeanor charge and potential civil liability for damages resulting from the failure to report. Simply informing hospital staff does not satisfy the reporting requirement. Suspected abuse or neglect must be reported to law enforcement. Providers who report suspected abuse or neglect in good faith are protected by immunity under the law. Likewise, patient confidentiality does not provide a legal justification for failing to report suspected abuse or neglect. After this class, I encourage you all to review the protocol and become familiar with its requirements. The protocol includes contact information for reporting and resources to answer questions. If law enforcement is not on scene, the protocol outlines alternative methods for making the required report. Documentation is key on these calls. Many of these have the potential of going to court or being used in proceedings. Document what you see, not what you think. Avoid terms like the patient appeared abused. Instead, describe the abuse such as bruises, 3 centimeters by 5 centimeters, dark purple, right cheek, that kind of stuff. Quote the patient exactly. If they say, "He hit me," then write that. If caregiver statements conflict with injuries, document the discrepancy, but do not interpret it. Like stated a minute ago, we are mandatory reporters. This includes suspected, not confirmed abuse. You do not need proof. The legal definition of abuse is any recent act or failure to act on the part of a parent or caregiver which results in death, serious physical or emotional harm, sexual abuse or exploitation, or an act or failure to act which presents an imminent risk of serious harm. There are different forms of abuse, including neglect, physical, sexual, and emotional. If you fail to report, you can be charged with a Class 3 misdemeanor and be liable for damages caused by failing to report. When in doubt, contact medical control or call the phone numbers listed in our protocol to get guidance. Caring for at-risk populations is one of the most difficult, emotionally charged responsibilities in EMS. We may only spend a few minutes with a patient, but those minutes can represent their one opportunity for safety, honesty, and hope. When we talk about recognition saving lives, it isn't an exaggeration. A bruise you notice, a story that doesn't add up, a child who won't make eye contact, a caregiver who interrupts every answer, these subtle signs may be the patient's only cry for help. If we don't see it, no one else may. Your documentation becomes the patient's voice long after you leave the scene. Objective, detailed, factual reporting is not just paperwork, it is evidence. It can protect the patient, protect you legally, and guide investigators toward the truth. A single well-written PCR has changed the outcome of countless abuse cases. Mandatory reporting isn't just a legal requirement. It is a moral obligation. You are not accusing anyone. You are initiating a process designed to protect someone who cannot protect themselves. When EMS acts, entire situations may change. Ultimately, EMS providers are more than healthcare workers. We are advocates. We step into homes behind closed doors and into moments of vulnerability that few others will ever see. Our role is not only to treat injuries and illness, but to ensure dignity, safety, and compassion for every patient, especially the ones who cannot speak for themselves. Your vigilance matters, your voice matters, and your actions may be the only lifeline an at-risk patient has. For wrapping up this lesson, I want everyone to discuss as a group a few of these calls that you have been on. Discuss what things went well and not, and things that you might change for future calls like this. I have personally been on too many of these calls and have learned from each of them. Good luck and have fun.